A very good morning to one and all. I'm Dr. Sankalp Naidu. I'm a radiation oncologist and a clinical oncologist. And I'm going to give you all a brief knowledge about colorectal cancers. March being the Colorectal Cancer Awareness Month, I'll be giving you an idea about the burden of the disease in the world and also in India. What are the risk factors? What are the signs and symptoms of colorectal cancers? And what are the treatment options over in India and abroad? So, and also I'll give you all an update on the latest treatment guidelines, the latest immunotherapies in colorectal cancers. So I'll be sharing my presentation. I'll give you all a brief introduction about colorectal cancers. So, okay. So, how to combat colorectal cancers? Coming to an overview, brief overview, colon and rectal cancers are cancers that involve the digestive system, especially in the lower part, the large intestine, and the rectum. The whole combined is known as colorectal cancers. It mainly starts as a polyp in the glands in the lining of both the colon and the rectum, and it gradually develops into a cancerous lesion. So I would like to give you a small idea about the incidence of colorectal cancers in India, because mainly we have learned about carcinoma, lung, breast, cervix, the head and neck cancers, but no one exactly talks about colorectal cancer. So actually, it's a silent cancer. So we'll just go on into the exactly how much is the incidence. Okay, the risk of colorectal cancers is the high among the northeast and also in the south regions of India, and we can see that males are comparably at the high risk. So I'll just give you all a small this thing. So the incidence of colorectal cancer is more among males. So in India, this is the source of India. So in 2020, this is the latest statistics of Globocon, which gives us the latest statistics about the cancer incidence, prevalence, and everything. So if you see over here, colorectal cancers rank about fifth of all the cancers. First is breast, second is the head and neck, lip and oral cavity, cervix, lung, and finally the colorectal. So, among males, which is more common, which we have seen that males are more common colorectal cancers, it is the fourth most common, which is after lip oral cavity, lung, stomach, and then the colorectal. So, among females, if you look into the statistics, it comes under sixth most common cancer overall among females in India in 2020. And first being breast, followed by cervix, ovary, lip and oral cavity, and then. So I would like to give a small instance about the overall, all over the world. The colorectal cancers all over the world, according to 2020, it is the third most common. First is breast cancer, second is lung cancer, and third is colorectal cancers. So, a brief preview, at least 60% of deaths can be prevented by early screening. It is second most common cancer-related deaths in the United States. There are many people, especially in the US, it is of a high incidence because they have a very high intake of red meat, alcohol when compared to Indians. They don't, they consume less amount of curd. I'll be telling you what are the preventive factors in the coming slides. Okay, what are the risk factors? See, I just wanted to give you all an idea. What are the risk factors of colorectal cancers? Majority is sporadic. Sporadic is which can come at any time because of any factors, individual factors, not relating to family or anything. So next is the familial factors, which mainly comprises of hereditary non-polyposis colorectal cancer, that is HNPCC. I'll be talking about this a lot. FAP syndrome, familial adenomatosis polyposis syndrome, and rare colorectal cancer syndrome, which is less than 0.1%. So a small thing is that this is an approximate lifetime risk of colorectal cancers. So if there are more than one mutations or two mutations in specific members, or if they are first degree and second degree relatives, okay, the incidence increases. And if there's a HNPCC mutation, the incidence is 70%. So this is a 70% lifetime risk of developing colorectal carcinoma, especially in HNPCC. So first degree and second degree relatives is also very important. If there's one first degree relative, it is 6%. If it is two, 17%. One first degree and two second degree relative is 8%, and one first degree relative less than 45 years of age, and the risk jumps to 10%. So if you just see the risk, FAP contains the highest lifetime risk of 95%, HNPCC mutation of around 70 to 80%, inflammatory bowel disease is 15 to 40%. So a small note on genetics, APC gene, you just remember that there are certain genes which either prevent or cause cancer. So APC gene is a tumor suppressive gene which when mutated uh, can cause colorectal cancer. KRAS is also a very important proto-oncogene. MY gene, DCC and P53, which is a very, very important tumor suppressor gene, which can cause mutation can cause many, many different type of cancers all over the body. So 75% of colorectal cancers, P53 gene, which is a tumor suppressor gene, is involved. So what are the other factors? Race and ethnicity. Higher rates and mortality are among blacks than whites. Socio-economic status. There's possible association between a low socio-economic status and a colorectal cancer mortality because of the non-proper intake of food, taking high alcohol and things like that. So alcohol, it is somewhat controversial, but appears that high alcohol intake increases risk. And tobacco, nonetheless, tobacco causes colorectal cancers. Most studies indicated not only colorectal cancers, it has been proven that tobacco can cause 76 different types of cancers all over the body. A single cigarette can cause 15 mutations in the body, and majority of it is corrected, but after a certain time the body gives up. It will not correct the mutation, and gradually it will call dysplasia, metaplasia, and then finally into change into cancer. So fruits, vegetables, and fibers, association between higher intake of vegetables and lower cancer risk. So higher fiber rich vegetables, less the cancer risk. So higher meat intake, higher the cancer risk. So folate, high intake of folate is associated with lower colon cancer risk. Calcium, avoidance or low intake of calcium may minimize risk of colon cancers, especially for gluten intolerant people. So fat, carbohydrates, and proteins. Excess energy intake leading to obesity increases the risk of cancer, colon cancer. So possible association of red meat it is not exactly possible. It is there is a direct correlation of intake of red meat and increased risk of colorectal cancer. What exactly is red meat? Red meat is nothing but meat which is having red muscle fibers, which is mainly present in either beef or pork. Beef most commonly. So, how does this red meat cause uh, cancer, and other white meat, which is like such as chicken or most probably mutton, which is it has equal amounts of white and red fibers. So why does this doesn't cause colorectal cancer, and why does red meat cause colorectal cancer? It's mainly because of the muscle fibers. It mainly contains higher amount of red muscle fibers, which is difficult to digest. It takes a lot of time for a small quantity of red meat to get digested, in which the colon works, the over entire area of the colon works a lot in order to digest it. And after a period of time, it can cause pre-malignant lesions. So, lifestyle factors, higher BMI is associated with an increased risk of colon cancers, approximately twofold higher risk in individuals who are overweight or obese and who are more physically active. They have a lesser risk of developing colon cancer. So basically, in a nutshell, looking at the risk factors of colon cancer, the risk factors which we cannot change. Age. It is age related. As the age increases, the chance of having a colorectal cancers increases. Family history of colon cancers, as we have seen FAP, HNPCC, we just can't change that risk factors. UV or radiation exposure on a basis of who are working in industries or in aeronautical space have a higher chances of getting exposure to UV rays and indirectly getting a lot of skin cancers and colon cancers. Personal history of polyps or colon cancers, part of any syndromes, you have a risk. Inflammatory intestinal conditions such as IBC, inflammatory bowel syndrome, Crohn's disease, they also have high risk of developing colorectal cancer. And what are the risk factors which we can change? We have to focus on this. Physical activity. The person must have physical activity, not only prevents colorectal cancers, but many other cancers all over the body. Obesity we must keep our BMI within our normal limits and not be overweight, and that also can help curb developing the risk of colon cancers. Type 2 diabetes, even though if you're diagnosed with type 2 diabetes, we can actually revert it if we stick to lifestyle modifications. So we can actually curb in the developing of colon cancers. Smoking is a total no-no. It can cause 76 different types of cancers, and also it mainly depends on the diet. Higher vegetable intake, less meat intake, less, not completely no, but less meat intake in a limited quantities, then we can curb in. These are the risk factors. These were modifiable. In that we can change. So early signs and symptoms of colorectal cancers. You'll be seeing normally we have carcinoma lung, carcinoma breast. We get a lot of ads in TVs or in movies, but colorectal cancers are very less talked about. So what are the early signs and symptoms in which you can see that this can be colorectal cancers? So if you anytime find blood in the stool, frank blood, which is associated with pain or difficulty in passing or pain in passing stools, which is known as tenesmus. And also, if the color of the stool is also black, that means that it is an old bleed which has come into the feces. So, if there's blood loss, you'll have low hemoglobin count. So if there's like loss of weight, which we don't know the reason of, and changes in the bowel pattern, this is very important. There'll be alternate episodes of either diarrhea or constipation. So a person will be having either constipation followed by diarrhea, yeah, diarrhea followed by constipation. This is known as changes in bowel pattern. This mainly is caused by a tumor per se, if at all if present, or any polyps. So these can also be early signs or symptoms of colorectal cancer. The most common thing, abdominal pain. So I just wanted to give you all an idea. Why is this very important part? Why blood in the feces? So you can see that the area of the colon is very large. If at all, if you remove a colon, it will be a very large structure. So this is having a direct supply from the abdominal aorta. So a large amount of blood supply is given to the colon, and we can also see the venous supply. So that is the reason we have blood in stool. So what does a blood in stool tell us? So we can see that a sign of rectal bleeding is a sign of colorectal cancer. So what does it tell us? It can tell us that because of blood loss, there'll be anemia, there'll be weight loss, exhaustion, uh, the size of the stools will be decreased, and diarrhea alternate with constipation, which I have mentioned about bowel change in the bowel habits and changes in the excretory system. So these are all the things which can know that of there's blood in the stool. It can be because of anything, any injury, any infection, any bleeding from any polyp, or any cancerous growth. So I've already told you this is very, very important, which everyone must have an idea. Diarrhea, constipation, or feeling that the bowel does not empty completely. There will be a sort of feeling of the patient or the person that you have not completely gone to the washroom and something is still left, and you feel a little bit guarding type of pain in the abdomen, or while you're passing stool also you might develop pain. So this is change in bowel habits, which is very important. Unexpected weight loss of the patient. The patient is not on any diet, the patient is not having doing exercises, nothing, but there is weight loss. So always suspect it that it can be because of cancer. Cancer cachexia is one of the main cause because of the different types of products which are released by the cancer cells. Abdominal pain, discomfort in the abdomen, especially the patient will be having a bloated abdomen, frequently gas pains, fullness in the abdomen, abdominal cramps, especially in the lower and the left side of the abdomen, the most common site. So 23% have anemia, that is unexplained iron deficiency anemia. So mainly, if it happens in men, they feel exhausted. So they don't properly observe that they are having blood in stools. So they feel exhausted, and when you do a blood investigation, you find that the hemoglobin is very low at around 7 or 8, and the reason is not known. After long doing a colonoscopy, you find an unexpected polyp or a cancerous growth. So fatigue and loss of appetite, as I've already told you, fatigue can be mainly caused because of certain factors which are released by the cancer, or because of anemia. Loss of appetite, it is known as cancer cachexia. If at all, if it is caused by cancer, there will be a typical loss of appetite because of tumor necrosis factors and some interferons which are secreted by the cancer cells. So, what are the types of screening? Okay, so the screening for colorectal cancers is in an infant stage in India. But screening for colorectal cancers has been a part of screening schedules in the US, because the incidence is higher in the US, as we have already seen that it is the third most common in the this second most common cause of death in the US, whereas in India overall it is fifth and sixth. So, what are the different methods in which we can screen it? Fecal immunochemical test, or FIT or FBOT, in which we test for blood as a swab in bowel movement. You place it on a card, and it is done annually. Okay, I'll just tell the things such as GUEC, fecal occult blood test, which is done annually, and stool DNA, and double contrast barium enema. These are the four different types of screening methods which we can do, and the most easiest is the fecal immunochemical test, which is very easy, and fecal occult blood test. So the stool DNA is not available in many parts of India. It is easily available in the US. And double contrast barium enema, because this costs at around the upper two cost at around 1,000 rupees, whereas barium enema double contrast it cost around 6 to 7,000 rupees. So it is not affordable by many people in India. Colonoscopy, which is the safe, simple procedure which uses a scope in which we can directly see any polyps or any cancers, and it has to be done every 5 to 10 years, depending on the whether polyps are found. If you find a polyp, so one more thing I like to tell everyone is that there are normal polyps which are found in the intestine. If at all, if you have done a colonoscopy and if you found a polyp, it can also be a sessile polyp in which it will not grow, it will just be over there. So these are all normal, but we have to keep, we'll have to make sure that we keep looking at that polyp every 2 to 3 years. Flexible sigmoidoscopy and virtual colonoscopy, that is CT colonoscopy, in which we use X-ray, X-ray colonoscopic cameras along with CT scan. So, what are different types of screening, which I've already told? The fecal occult blood test, which is the simple most, it costs around 300 to 500 rupees. We just have to take the stool, dip the swab in it, and just check it into the for presence of blood. And the DNA test, it costs around 3 to 4 thousand rupees, which is not present in many parts of India. So here we can see that this is a double contrast barium enema, the area where there's actually a contrast fluid which is taken ingested and also which is sent parectally, and after ingesting the contrast, if it doesn't get uptake in this specific area of the colon, you can see that there's some sort of, not exactly colon cancer, but some sort of intestinal pathology over there. So sigmoidoscopy, this is a anus, this is a rectum, and this is a sigmoid colon. So this area of scoping the sigmoid with the thing called sigmoidoscopy, this is the most common site of colorectal cancers when compared. So colonoscopy, it is simple and a safe procedure. The patient is kept in a lateral position, knee chest position, and then the patient will be having a anemia prior to the procedure, and then a colonoscope is inserted. And this, you can see that this area, there's a scope and a light source, so we can see whether all the wall of the colon, the entire colon, and if we find any suspicious growth, there'll be also a biopsy trocar in which we can take a small punch. Here you can see that there is a polypectomy. I put a small video regarding polypectomy also. So virtual colonoscopy, CT colonoscopy, which I've already done, they'll be using both with the help of specialized CT scan to with some there's some latest MRI with endorectal coils, which gives us a even more better wall perception in for colon cancers. So I just wanted to give you all an idea about what is the mucosa of a large intestine, and with this is a different. If at all, if you take a transfer section of a large intestine, this is what you see in the microscope. It will be lined by columnar cells. For the next layer is the lamina propria. You have many goblet cells which go around and for intestinal secretions in many intestinal glands. And this is a lamina propria, and this is a muscularis mucosa. So these are very important to stage the colorectal cancers. So this is a normal epithelium, which you can see. So I have already told that APC gene, if there's loss of mutation in chromosome 5q, there's hyperproliferation, loss of DNA methylation, and this normal can change into early adenoma. Here you can see adenomatous polyp over here in this part of the colon. And then if at all, if there's KRAS mutation, chromosome 12p, there's intermediate adenoma. And if there's this is a DCZ loss, chromosome 18q and chromosome 4, it changes into late adenoma. And finally, P53 gene, which is a tumor suppressor gene, if there's loss, chromosome 17p, and finally it becomes into cancer. So it doesn't, any colon cancer, it doesn't turn into cancer overnight. There is a process, there is a change in or mutations which chronically happen in the area of the intestinal cells, and finally it develops into a frank mass, that is colorectal carcinomas. So a small note on staging, as we can see that the deeper it goes, the cancer goes, the higher the stage it is. So stage 0, also known as carcinoma in situ, meaning that the cancer is located in the mucosa. moist tissue lining the colon or the rectum, and a polyp, basically a polyp, which is a stage 0 colorectal cancer, is simple polyp. We can just remove the polyp, which is known as polypectomy, which is the usual treatment. And what is stage 1 colorectal cancer? It mainly invades the submucosa. The tissue which is below the mucosa is known as submucosa. Here you can see that the tumor. This is a tumor which is invading the submucosa, and mainly as it is superficial, you can just resect this area by surgery, and we'll have to remove the surrounding lymph nodes also. So what is stage 2 colorectal cancer? We can see that there are 2A and 2B. So if it invades beyond the submucosa into the muscularis propria of the colon and rectum, but has not spread to the lymph nodes. So this mainly is treated by again surgery, and sometimes if it is very bulky, we'll give a NSCT followed by surgery. And in rectal cancers, we give neoadjuvant CTRT followed by surgery. So in stage 3 colorectal cancer, it means that it even invades even more. So it has spread beyond the submucosa and the muscularis mucosa, and it has also spread into the lymph nodes. So it is mainly treated by surgery and chemotherapy, and rectal cancer is treated by surgery, radiation therapy, and chemotherapy. And what is stage 4 colorectal cancer? Basically, everyone must remember that cancer has 4 stages: 1, 2, 3, and 4, and majority of the cancers. So in the stage 4 means that the cancer has gone from that site to a very distant site, or a non regional lymph nodal site. So all this thing is known as stage 4 cancers. So a stage 4 colorectal cancer has gone spread outside the colon or rectum to other areas of the body. So mainly it is treated by palliative chemotherapy, and if at all if there's a very big mass which is causing obstruction or anything, you can go for debulking surgery. And if at all, if there's a single metastatic, because we are in 2022, the latest guidelines, latest treatments for different even for stage 4 colorectal cancers. We are not in the early 1990s. We are in 2022. We have many different targeted therapy, targeted radiotherapy, SBRT for oligometastasis. We have many different drugs which are developed for, such as immunotherapy also, which we can use for the treatment of stage 4 colorectal cancers. So mainly, I would like to to tell you one more thing, is that what is the stage of diagnosis? So mainly, most commonly, we see that the disease in which we mainly find it in stage 3, regional spread to the lymph nodes. So the patient majority, they don't come in stage 1. In my practice, I rarely see stage 1 or stage 2, but majority is either stage 3 or stage 4 in what I'm seeing in my OPDs. Hope all the other oncologists also agree with me. So distance metastasis cancer, it has been mentioned 19%, and also localized confirmed to primary is also 39%, and unknown stage is 5%. So what are the treatment options? We can have either surgery, radiation. The role of radiation in colorectal cancers is very limited, but surgery is a main part of treatment. Chemotherapy, targeted therapy, and finally immunotherapy. So, stage 0, polypectomy. 1, surgical removal of the tumor and the lymph nodes is usually the only treatment. Stage 2, surgery plus adjuvant chemotherapy. There are many different regimens, different things, different sites of the colorectal cancer. For colon is different, for rectum is different. Adjuvant chemotherapy if there's any localized presence of the disease. For rectum, radiation plus chemotherapy, neoadjuvant is CTRT, followed by surgery, which is the most common. Even for stage 3 also, for rectum, you have the same thing. Stage 4, combination of surgery, radiation, immunotherapy, targeted therapy, chemotherapy, and finally palliative care. We have many options for stage 4, but in the final things, we can't save the patient after a long period of time. So surgery, polypectomy, especially for stage 1, there's a single polyp. How do you remove it? You have this endoscope, you have this polyp, this is a polyp, this is the colon mucosa. You have this polyp and you just put a scope which has a trocar, and it just goes around the polyp, and it just cuts off the blood supply after this thing, and just you lift it, and I'll just show you a small video also. So you can see that this trocar, this is a polyp in which he's trying to, he put up a trocar and he found the polyp. This is a polyp which is attached to the intestinal wall. You can see that how he's trying to put the trocar around the polyp, and then he pulls it out. So this is a simple polypectomy. This has sometimes because it is supplied by a blood aberrant vessel, so it bleeds when you do a polypectomy, which is normal. It's just simple excision of a polyp. So laparoscopic surgery, here we can see that there's a thing called laparoscopic. All now, nowadays many are into the not agreeing for open surgery. Many go for laparoscopic surgery because of higher advertisements, robotic surgeries. Da Vinci, many people, many patients ask, sir, is this a very, you have to, you'll put a, will I have a big scar or will I have a small scar? So our surgeons, they go for laparoscopy as an option, give it as an option in which small incision will be there on the surgery and is more amenable. Various surgical procedures such as right hemicolectomy, left hemicolectomy. This part of this blue color part is being removed in all the things. Transverse colectomy. It depends on the area of the growth in the colon. So sigmoidal colectomy, subtotal colectomy, in which the entire part is this thing. And ultra low is LAR, which is the most common thing. Lower anterior resection, and also APR, which is abdominal perineal resection, is also very most common surgical procedures. So colostomy. One more thing I'd like to give you all an idea is what is colostomy. So if at all, if there's cancer over here you can see the part of the sigmoid colon. Just added to it, you can find the growth. So this growth, we just cut the colon up and below, and after we cut the colon above the cancer, we put that cut end of the colon outside of the body, and they put a colostomy bag. So, and this area is removed, and this area we keep it for at least 1 to 2 months for it to heal. So the colostomy bag is there, in which the things which the patients eat and everything gets collected, goes through the stomach, the small intestine, finally into the colon, and finally it comes out through this bag. This bag can be removed and it can be changed. So, chemotherapy. We have seen the surgical options of the treatment of colorectal cancers. Now coming to chemotherapy, there are many regimens for colorectal cancers. The most common being Capox, Folfox, Folfiri, Flofox, Folfirinox, Folfoxiri. There are many different. These are all different regimens which contains most commonly few capecitabine, oxaliplatin, leucovorin. They are most common drugs. So as you can see that these purple color things, these are the chemotherapy agents. So finally, uh, it acts in such a way such that the cancer growth is inhibited. So there are many different pathways, such as TP53 gene is there's loss, and it and the cancer cell grows and on. So this there's a division of a cancer cell. There's a different stages. So these take parts at these specific stages of the cell cycle, and finally it can cause different types of things, such as there's no DNA repair, there's apoptosis, and finally there are different mechanisms, and finally it leads to cell death. That is the cancer cell death. So chemotherapy may be given after surgery to eliminate remaining tumor in colon growth. Mainly, it is given an adjuvant treatment. In rectal tumor, chemotherapy and radiation is given before surgery, which is known as neoadjuvant, to reduce the size of the tumor, and then finally the surgeon will resect the tumor. So we also have targeted therapy. such as VGF inhibitors, such as bevacizumab, aflibercept. So these are VEGF inhibitors directly actually vascular endothelial growth factor inhibitors. So actually this decreases the blood supply to the tumor. If the tumor doesn't have blood supply, naturally it will not grow. It doesn't have the nutrients to grow. So indirectly it cuts off the blood supply, and finally it basically binds to these receptors, and then finally it causes tumor uh, growth is lost. So we have many other things such as EGFR inhibitors, which such as cetuximab, which binds to the EGFR receptor. These are the latest targeted therapies. This directly goes and binds to the surface of the tumor cells, which has this EGFR receptors and VEGF receptors, cut off certain signals, and finally cause apoptosis and finally cell death. So you can see that decrease this if Jeftinib will cause all this pathway will be hampered. So, what is immunotherapy? These are the latest treatment in the 20th century. So, CTLA4 inhibitors such as ipilimumab, temolizumab, these go and bind to the CTLA4 part of the T cell, which is known as the scavengers of the body or the policemen of the body. These goes and bind over there, and it will tell the T cells, this is a colorectal cancer cell, come and fight it. So actually, how does a cancer cell evade? We have natural immune systems of our body. So how does this cancer cells evade this immune system of our own body? So what does it do? It has certain receptors over it, the cancer cells. So it will mimic the normal cells. So it will indirectly hide between the normal cells, and it will tell the T cells that I'm normal cell, don't attack me. So what does these do? Ipilimumab and these immunotherapy agents, it will bind to this T cell, and it will tell that it will scavenge all over the body, and it will tell that this is a cancer cell, such as PDL1 receptor. It will go and bind to this PDL1 receptor of the cancer cell, and finally cause the death of this cancer cell. So there are many CTLA4 inhibitors, PDL1 inhibitors, and PD1 inhibitors such as nivolumab and pembrolizumab. These are the latest treatments which are given mainly in stage 4 and sometimes in stage 3. So how do you prevent colorectal cancers? Eat a lot of diet rich in fruits, vegetables, having containing higher amounts of fiber and whole grains. Limit intake of meat, any form, not only white meat, red meat, anything. So the more fruits and vegetables you eat, the less the cancer risk. If at all, if you have a colorectal cancer person in your family, nothing to get scared. You have to go and get yourself screened. You have to see there many. You'll have to visit an oncologist. There are certain risk factors and risk algorithms which are available online also. You just have to type first degree, second degree relatives and everything. They will tell you that algorithm tells you the risk of developing colorectal cancers, and you just have to have a broad thinking that it is preventable. So if you have a risk, if you do a lifestyle modification, then you have lesser risk of developing colorectal cancer. So physical activities are a very important part, especially at the abdominal area. The amount of fat must be in the limits, and maintaining healthy weight. So I've already told you, cigarette is a total no-no. 76 different types of cancers can be caused by proven cancers can be caused by cigarettes. So totally quit cigarette, even passive smoking. Don't ever think that I don't smoke, though so I won't be getting. Even though if you inhale passive smoke from a cigarette smoker, which is who is beside you, you can also that is also harmful and dangerous. Alcohol limited, that is also a no. Who should be screened? So average risk patients more than 50 years of age, these actually who to be screened, the different types of risk patients: average risk, moderate risk, mild risk, and severe risk. So more than 50 years you are at a risk because of the age. No history of colon polyps, also no family history, they also comes under average risk patients. The incidence of CRC in younger adults less than 50 years have been increasing 2% per year since 2003. The American guidelines, they now recommend average risk screening begins at the age of 45. What to do? A colonoscopy every 5 years. And if at all, if you develop any symptoms of which I've told you previously, then you'll have to go for, you'll have to visit the oncologist. And mind you, we, we see a lot of people referring Google. If at all, if you cough and if you have blood, or if at all, if a single episode of blood in feces is not cancer, it can be pre-malignant lesions or a simple polyp also. Don't go straight reading Google and going into all decisions, and don't take self investigations. Kindly visit any oncologist and then take a proper guidance and then go forward with your screening. So increased risk patient, in which we'll have to do screening into more frequently. Family history of more than one first degree relative with colorectal cancers, and you'll have to start at the age of 40 or 10 years before diagnosis. If any relative has, for example, here, if any relative is diagnosed with colorectal cancer at the age of 50, you have a chance of developing cancer 10 years before him, so at the age of 40. So it's just like that, and repeat at least every 5 years. So worst degree relative with advanced polyps start at the age of 40. These are all APC guidelines. Personal history of advanced polyps, IBD or colorectal cancer, you'll have to again, previous history, the same patient has polyps or inflammatory bowel disease or colorectal cancer, again you'll have to screen. Finally, a summary. Colorectal cancer is a common but a very treatable cancer, and screening starts from the age of above 50 years to 75 years to reduce the incidence of advanced adenoma, which is a strong recommendation by the NCCN and the other guidelines. Family history and personal history plays a very important role in your risk for developing colorectal cancers. So we'll have to screen by colonoscopy. It can prevent the cancer by removing any, if at all, if there's a incident polyp which is developed, which has been born in colonoscopy, we can just remove it by polypectomy, and we can detect cancer earlier, and it is more treatable. A high healthy fiber diet, of a diet rich in fruits and vegetables, exercise, and avoiding alcohol and tobacco can reduce or lower the risk of developing colorectal cancers. Not only colorectal cancers, this can reduce approximately more than 50 types of cancers in the whole body. So colorectal screening rates must be optimized to reach the aspirational target of decreasing incidence by more than 80%. So it is time to get screened. And the blue ribbon, always every cancer has a different ribbon. So the ribbon for colorectal cancer awareness is a blue ribbon with a blue teal, and March is colorectal cancer awareness month. So we'll have to be aware that cancer, colorectal cancers are also rampant in India. Not only carcinoma breast, carcinoma lung, and other cancers, colorectal cancer is also there. And these are the signs and symptoms, and how to what are the risk factors, how to screen yourself, and what are the treatment options has already been done. Thank you.